Hello, I'm Lorna. If you're getting an ABF monthly reporting email once a month, hello, it's me. I'm the person sending you the email every month or requesting details for you from Access, so just to put a face to the name. I'm going to go through some work we've been doing in outpatients. We presented a little bit on this last year, but we've made a little bit of progress, so we're just going to go through a quick reminder of what we've done with ABF and outpatients, and we're going to have a little classification and what we've done on UL so far. So, as the lads have all said, outpatients is part of Sláinte Care now. Moving outpatients into ABF, the collection of data for outpatients is part of our ABF implementation plan. Currently, there's about 3.5 million attendances at outpatients, 1 million new, and the balance is review. It's estimated 500,000 of those are DNAs, so people who fail to attend. On average, an outpatient attendance costs €190. That's a very high level average. We don't have any detail in terms of the patients or the complexity of the patients to actually map to that. So we don't have the information, and each hospital defines their directorates and their information separately, so we can't do that consistent comparability across sites. So we're missing the information. If you think of all the data that we have for HYPE, comes to outpatients, we don't have the demographics or who was treated. We don't know what they were treated for, really. We don't know when they're there, what the kind of frequency of times, the days, the peak hours. We don't know really who are DNAs. We need to know where they're being located. There is that crossover between day case areas and diagnostics and hospital locations, and we really need to know that information. And why are they there? What is the purpose of the visit? What clinic are they attending? So if you have to classify 3.5 million attendances, you do not want to code that the way we code HYPE records. The HYPE coders would not be able to do that. It would not be fair to ask them to do that. So we've taken on the Tier 2 outpatient clinic definition from Australia. We're calling it the outpatient classification system. We've Irishized it. So basically the homogeneous groups that we're going to map the clinics to are called outpatient clinic groups, or OCGs, similar to our DRGs. It's a structural hierarchy. It's based on provider and activity. The granularity and the specificity ensures a sufficient coverage of the hospitals, and it was developed for the purpose of reporting and for funding, and it underpins the logic associated with our inpatients and day cases where we map to DRGs. So you have that level of hierarchical consistency from your inpatient, your admitted setting to your non-admitted setting. So we have kept the original version and we've amended it and modified it to suit the Irish system. We are now on version 5 of the OCGs. That's 146 different OCGs for clinics to be mapped to. We've kept it updated for the COVID back in 2020, and I updated it in March 2023 to better capture activity associated with long COVID. There's also new clinics in there that might not necessarily yet fit into the Irish system, but they're new for the Australian system, and to future-proof it, I have added those clinics in. So you might look at the classification and go, this doesn't map to me, but it's something that is either community-based or home-based, and it may be something to be in the future. So it's anticipated that the outpatient clinic groups will be more effective at reflecting equal payment for equal output regardless of service location. So you've got your 4 classes. You've procedural clinics, which are the 10,000s, 20,000 is medical consultation clinic, 30,000 is standalone diagnostic outpatient clinics, and the 40,000 is your allied health, clinical nurse specialist or nurse practitioner. There's a couple of examples there what kind of OCGs are within each one. Surgical, minor surgical for procedures, kind of general surgery, geriatric for your medical consultation, clinical measurement for standalone diagnostic for outpatients, and then for your allied health, it's that ox therapy, wound management, cardiac rehab. So each one of those 146 OCGs has what we call a data element definition. And this is where the hierarchical structure and the decision tree effectively is there for each one of the OCGs. So this is minor surgical, it's 10,030. It tells you that the usual provider is a surgeon or anaesthetist. The definition of the service for that OCG is that the conduct of minor surgical procedures that do not require the patient to be admitted to the hospital, the services may require the use of a specialised procedural suite and or anaesthetist services. It tells you what to include in that, biopsies, excisions of lesions, joint injections, but it also tells you what's not included in that. So if it's dental procedures, you go to your 10,040. If it's any kind of endoscopy, if it's gastrointestinal, it goes to 10,060. So as much as it tells you what the definition is, it also has that decision tree process to tell you where else to go. This is just a medical consultation one. This is general medicine, so it's 20,050. Usual provider is a specialist physician. And again, it's for general medical conditions, but it has the exclusions of if it's geriatric medicine or pediatric medicine, you go to these other OCGs to capture that information. So each one of the 146 OCGs has these definitions of service. The process of mapping to a particular clinic to an OCG, you're looking at your definition of service, you're looking at your specific rule sets, and it's the assignment of those different things brings you to your OCG. So ultimately, we would want, anytime an outpatient manager is setting up a new outpatient clinic, they're thinking, I want this for activity-based funding, I want to put a euro sign over this clinic, what OCG do I need to assign? It has to be part of the standard operating procedure. So your clinic category straight away breaks it down, who's providing the service, what's the definition of the service, my inclusion, my exclusion, it brings me to the OCG. That will do for about 99% of all of your clinics. There'll always be the outliers. There'll always be the 1% around the edge where you're looking at the cases where the clinic performs a range of different health services within that clinic. And the designation then becomes more difficult to look at. And in that case, you're looking at the predominant activity. If the predominance of the activity is procedural and there's a little bit of medical consultation at the side, that's the secondary activity. The predominance is the procedural activity. If you have a medical consultation and maybe a physio comes in and that's the secondary activity, the predominance is the medical consultation. So it's just to be aware that there is rule sets around also what actually assigns your OCG. We've also developed an outpatient clinic register to support this process. One of the software developers, Joe Hunter, has developed this for us. This is to capture, it's a web-based tool, so you don't need any software. This is to capture outpatient clinics where the OCG is classified. We need information about the clinic to decide on the OCG. We also need the descriptors around the clinic. So we capture the clinic descriptions, the location, whether it's public-private, what's the mode of delivery, if it's a joint or shared clinic. The classification gives us the specialty, whether it's procedure or medical, the OCG, and a description around that and the consultant information. And then really importantly is the clinic timetable, because that's where the resource intensity goes. Is it a multiple consultant clinic? Is there many consultants in it? Because the resource is the salaries and the cost associated with running that clinic. And by capturing that information, it tells us where the resource is going for those particular clinics. We have this clinic register. It's quite small there, but it's all just drop-down fields. So it's quite simple to just pick down your hospital, your consultants, give us a description of the clinic, where's the location, you fill in your timetable. It's like booking a flight on Ryanair. There's nothing more difficult in it than that. You're putting in your specialty, your consultant. You pick your OCG. So your outpatient manager or your outpatient clinic people pick the OCG that they want. They tell us why they picked it, because that way we can give them advice and help them if they're unsure of what's the case. They send it in to us and we either approve or we give them advice that maybe a different clinic might be more appropriate. Maybe they had picked general medicine and really they should have picked geriatric medicine. It's as simple as that. We then approve it and we give them back a code. At the moment, and this is just IPIMS, I know there's other voluntary sites of different systems, but for IPIMS at the moment, we've identified a field on the outpatient clinic setup window, which is called CA serial number, which is a very strange name, but we've identified it to capture the OCG. It should be rolled out in IPIMS version 8, that we're going to change the name and make it a drop-down field. At the moment, it's a unique code, and we will give you the code to actually put into it. We don't want to delay, we don't want to wait, we want to move forward. So when we move over to that drop-down field, we'll actually transition across voluntary sites. As we move through the different sites, we will actually identify what's the best way to capture it. So you have all of your clinics, they have to be assigned to an OCG. We're currently working in Limerick at the moment at this. So what we've done is instead of them having to sit and do data entry for every single clinic into that portal that we have, we're basically saying, give us a database and we'll load it through the back. We'll do a tranche, we'll get everything loaded, we put all the information in, save people having to do data entry. Once you've loaded all your current clinics to date, it's just the maintenance going forward that happens in the online clinic portal. There's nothing additional to that. So as you can see there, the information being collected is as per the outpatient clinic register, but we'll load it in, we'll fill it, and then going forward, it's just the maintenance or the additions that have to be added in. Parallel to that, we're also looking at an outpatient minimum data set. This is to capture the activity side of the clinic. So we identified 41 variables from the outpatient minimum, the OSPIP minimum data set previous. We just want to describe variables that describe the attendance, the demographics, the classification. We're working with BIU, we're working with acutes. We want to come up with a list that suits everybody. Collect once, use often. We don't want to be continually going to hospitals asking for information. There's currently no data capture present. We're working with IIS and the OCIO to actually get that information. And hopefully in version 8 of IPIMS, we'll actually be able to capture the OCG properly. So how does this work? Basically, a hospital requires an outpatient clinic. They come to their IPIMS or PAS clinic setup window. The OCG is a required field. They come onto the outpatient clinic register, they register it, they tell us what they think the OCG is. We go, yes, we agree, or no, we think it's this. They go back in, they put the code onto IPIMS, and then the OCG sits on your IPIMS or your PAS. Nothing has to be done past that point. You're done. Every patient attending for an appointment will be assigned the OCG based on what's on the PAS or the IPIMS clinic code. It'll just be sitting there in the back that it can be pulled. You then have your clinic register, becomes your national outpatient clinic register in terms of services and what's operationally happening. And each hospital then rolls up to a national outpatient database. The same way we have HYPE with our DRG, we'll have outpatients with our OCG. And then we can actually do our modelling of our data. So what does implementation look like? You have to assign the OCG classification. Your OCG clinic register has to be updated. We do an extraction process. There's continued support and maintenance from the HPO, but it goes from being the implementation stage to being operational. This is not a pilot, this doesn't stop. This goes from being implementation to operational. And it becomes a standard operating procedure to add your OCG to your clinic when you're setting up your clinic. You want to put your euro sign over your clinic because you want your activity to be recorded and you want your value to be included. What does that look like in Limerick? We did a pilot with Limerick back in 2019. We had mapped loads of clinics. We had started importing into the clinic register. We had a go live meeting the week that Limerick had to close because of COVID and everything stopped. And between COVID and the cyber attack, we couldn't get going again. We got approval from the CEO of the Limerick Hospital Group to recommence the implementation project at the end of Q1. We held meetings with senior representatives in UL from finance, clinical, operations, outpatients, IT directorates. And it was really positive. Everybody could see how if you have what should happen in your outpatient clinic and you have your activity of what actually happens, you can compare one versus the other. You can see what's a productive clinic. You can see what your throughput is. You can see where your costs are going. Straight away, everybody could see what was happening. For the outpatient clinics, we've all of them identified in UL. We've identified all the required characteristics. There's 1,000 approximate clinics in the whole of the UL group. It's going to take us time to map it. Once we map it, it's done, and then it's just the maintenance going forward. We've commenced the mapping process. We were in Limerick on Monday, my colleagues Fionn McCarthy and Audrey Allen, and we started that process. We met with the HPO or the UL outpatient team, Julia Carter and her team, and it was a fantastic meeting. I think we learned more than they did because we were able to test what we were doing to see whether it actually worked, but it was really great. The benefits of the data is you're going to have extensive information about how your outpatient is operating clinic-wise. You're going to have better data to make informed decisions, evidence-based policy decisions. If you need systems in your hospitals and you can put a euro sign over your outpatients with the clinical information behind it, that makes a big difference when you have to go looking for money. Every person attending outpatients is consuming a resource, and to be able to do ABF in outpatients, we need to identify the activity, classify the activity, cost it, and ultimately give the appropriate funding for the correct activity. Moving forward, we have got great work done with the UL group. It's been really positive, and we have a strong basis for progressing. It's not just a HBO approach. This is national. We're working with acutes, we're working with BIU, we're working with the OCIO, IIS. It's driven by Solange Care. This isn't just a HPO. We're moving forward. We're going to collect once, use many. We're going to have consistency of classification and minimum data set. And we might need to develop the classification and the minimum data set as we go from site to site. But it is a developmental process until we become operational. So currently we're at UL. We're going to hopefully move to other nominated groups. We'll keep the conversation going with the sites that we move through. Your OCG becomes part of your standard operating procedure of setting up your clinics. That way you get your Euro sign over your clinic. If you have all this information, it makes future planning, it puts value on your data, gives you consistency, comparability, and it gives you credit for the work that you're doing, because I feel that 3.5 million attendance in outpatients is probably the low bar of what's actually happening, of what's going on there. It's not a pilot, it's implementation, and we're going to go to operational. So if you see the name Lorna Collins appearing anywhere in emails begging for you to be part of the implementation, please be nice. Please, I'll bring biscuits. I'll be available for any kind of meetings, but hopefully we'll move forward with that. So thank you very much for your time.